Good morning to one and all present here. I'm Dr. Vidushi S. Dixit, and I'm a second year PG trainee in SSDN Guwahati. I'm here to present a case on a case of failing bleb and acetazolamide induced choroidal detachment. We have documented this case extensively. However, due to paucity of time, I will try and highlight only the significant points. So here's a case of a 58-year-old male who underwent trabeculectomy with phacoemulsification and subsequent bleb needling, who developed bilateral choroidal effusion a day after, likely due to acetazolamide usage. So he's a 58-year-old male hailing from Assam, who was an already diagnosed case of glaucoma for last 7 years with a positive glaucoma history in mother with a known diabetic. He was already on treatment but was not very compliant with the treatment. This was his previous prescription. As he presented to us, these were his baseline parameters. We noted the visual acuity to be 624 N18 BCVA with a cataractus lens and an IOP of 24, CDR ratio of 0.9 with pale NRR. Therefore, we went ahead and did baseline investigations for the patient, and a provisional diagnosis of primary open-angle glaucoma with cataract with refractive error was made. Thereafter, we started the patient with AGM. However, the IOP was not controlled, remained 24 even after a monthly follow-up. We stepped up the AGM. It still did not get controlled, and therefore it remained 22. Even after the maximal medical management, we could not control the IOP. Therefore, we had to resort to surgical treatment for this patient. On post-op day 1, the IOP was 20. However, after 2 weeks follow-up, it shot up to 25. And that's when we suspected that this could be a bleb failure. And as a resident, I started the patient on acetazolamide. My consultant suggested we must go ahead with bleb needling and MMC. However, next day, to my horror, the IOP shot up to 40 with marked chemosis and congestion, and the AC was shallow in both the eyes. I don't underestimate. I looked exactly like how that Tom is looking. On USG B scan, it revealed shallow choroidal in the right eye and choroidals with suprachoroidal echoes and effusion in the left eye. And we felt devastated as to what happened. But sometimes big problems can have simple solutions. Just discontinuing the acetazolamide, giving mannitol to the patient, an anti-inflammatory and cycloplegic treatment. After 1 week, this patient came back with resolution of these choroidals. IOP was still on the higher side though, but the choroidals had resolved. Eventually, after the patient was still kept on AGMs, and eventually after 1 month, the visual acuity was 6.9 and the IOP was well controlled, 18 millimeters of mercury. The learning point here is that we must keep choroidal detachment in our minds whenever we are prescribing drugs like acetazolamide. The likely etiology here was an idiosyncratic reaction, which I later found out was already described in the literature, but I did not know of. And this could cause a ciliary body edema leading to secondary angle closure glaucoma, which is likely the reason for high IOP in our case. And the signs and symptoms of choroidal detachment must be kept in the back of our heads whenever we are prescribing acetazolamide. And the treatment, as we said, we must discontinue acetazolamide, start the patient on systemic steroids and cycloplegics. Such cases have already been described in the literature earlier as well, which again I found out much later. The learning point is that please, we must be extremely judicious in prescribing acetazolamide. Thank you.
Yeah, good case, Vidushi.
Thank you, sir.
What is the status of other eye?
So the other eye was absolutely normal to our surprise, but
Quite unusual.
yes.
How old was the patient?
58-year-old, sir.
58-year-old.
He had a positive history.
Unilateral open-angle glaucoma. Right eye did not
show any changes. We did an OCT RNFL also, sir, which was reportedly normal in the right eye.
Pressure was always normal.
Yes, sir.
Perimetry was normal.
Yes, sir.
That is quite
unusual, sir.
Because having only unilateral and that too so advanced, was there any history of steroid intake?
No,
sir. Did you take history?
Yes,
because
sir. Yes,
unilateral open angle glaucoma, you have to find out some other cause also, some secondary cause also.
Yes, sir.
Because it is very unlikely although the presentation may be unilateral to begin with, but ultimately it become bilateral. It is asymmetric disease.
Yes, sir.
But having no change in one eye and advanced 0.9 cupping in other eye should make us think that there is something more to it which we are missing.
Yes, sir.
Right. Okay, that's very important message that we give acetazolamide left and right, but we should be aware. Like in this case, there was choroidal effusion following this, which you could found on this thing, E-scan,
Yes, sir.
and that led us to the diagnosis of the choroidal effusion following acetazolamide therapy, which led to secondary angle closure. So this is not, since it's not a pupillary block mechanism, PI is not going to help, and like you mentioned, pilocarpine should be avoided
Yes,
because
sir.
that will really precipitate. I think any question from the audience, sir? Yeah, Dr. Kashyap, sir.
Sir? Yes, sir. The very next day.
No, you did needling.
Bleb needling, sir.
How many days after phaco and trap? This was combined phaco and trap.
Yes, sir. Sir, it was almost about a month later. We had to after 2 weeks, we found out that the IOP was not controlled, shot up again. That's when my consultant prescribed that we must do.
Just a
bleb
month after
needling.
the surgery, you did
Yes,
needling?
2 months after the surgery.
2 months after the surgery, you did. The misdirection will not lead to, because the choroidal effusion will not occur due to misdirection. It may, misdirection will lead to something like malignant glaucoma. But the patient had documented choroidal effusion.
Yes,
So,
And then there is a misdirection of the aqueous from the anterior chamber towards the above the ciliary body and then goes behind the choroid. I had such incidents, that's why I have.
so okay.
Thank you, sir.
Thank you. Any other question? Doctor.
Sir? Yes, sir. Seedles was negative for the patient, sir. There was no likely bleb leak.
So there may be long-term hypertony that might have led to
But sir, the IOP was high on the higher sides.
IOP was 40, I think.
Immediately after, IOP was 40.
IOP was high. So there should have been hypotony. But here the intraocular pressure was very high. Yeah. Okay. Any other questions? Any questions on any of the presentations or any comments?